Just wanted to say hello to you all. We're on the home run now, nearly there. You've all been very patient and paid good attention to all of the speakers today. Just to introduce ourselves, my name is Julie Emerson. I'm one of the specialist AHPs for the neuro-oncology team. And this is...
I'm Sara Robson, the other specialist AHP for the team.
We do come as a pair. Anyone who knows us will know that. So we'll be chipping in together throughout the talk today. We both work in the primary brain tumour service, and our job is to coordinate the rehabilitation for patients across the Greater Manchester area. But we're talking to you today about rehabilitation needs for people with brain mets. I know this is a bit of a difficult slide, but it's almost the question you ask, so what is the point? And it's an unspoken concern really for people who are professionals about whether to refer people with brain mets to rehab services, but also for patients as well, because they're often, if you have a conversation with them, will say, well, you do know I've got brain mets. Why would I need to be referred to rehab services? I think this phrase gives you an idea of what it's all about. So whatever we call it, reablement, survivorship, rehabilitation, it's about the person, not the diagnosis. Just wanted to talk to you first of all about our values. The first thing that we believe in our team is that care is based on the need and not diagnosis. The challenge around services locally and also nationally is that services are sometimes organised based upon different pathways that people fit into. For example, there might be stroke services, there might be palliative care services, there may be musculoskeletal services, and our patients have different needs that sometimes fit across those different pathways. And you might find that the services that they need aren't always available for them. So it's quite important for us that the care that people receive is based upon their need. The other challenge is that people might have quite mild problems that don't trigger a referral into a service normally. But although the problem is mild, it actually causes them quite a lot of physical, psychological, emotional, social distress. So it's still a high need for that patient. Other patients might have quite severe problems, but not find that has a big impact upon them. So I think it's very important to think about the need of that individual. I think it's a repeated theme throughout the talks today about this individualisation of care, isn't it? The other challenge is equitable access to services. So you're all from different places, and we know that across the Greater Manchester area, it very much depends on where you live in terms of what services are available. But the idea of having equitable services fits in with the 5-year forward plan, and the aim of that is to close the gaps in quality of care and funding of services which result in inequity. The problem we have is that patients still have different experiences of rehabilitation across different areas. All patients have goals they can work towards. We quite often hear that people don't have any rehab goals, and again we would challenge that really. All people do have things they want to achieve, whether that is being able to be able to sit out into a chair, whether it's to play with their children, whether it's to put their makeup on. So Sarah and I are advocates for patients being able to be supported in the goals that they do have, even if they are small goals. And the NHS Outcomes Framework for 2016-17 actually supports this as well. So Domain 2 is around enhancing quality of care for people with long-term conditions, and Domain 3 is about helping people to recover from episodes of illness. So if you're wanting to get some support for developing services in your area, always go back to the publications that have been produced recently. And the other value that we have is that cancer and rehab are not mutually exclusive. So there's a concern from professionals and patients, as I said, that a cancer diagnosis means rehab isn't appropriate, possibly due to patients' prognosis, but also because of treatments. So the timing of treatments, sometimes professionals struggle with to know when to be able to see patients, to see them at home, to be able to make appointments, etc. Or with the effects of treatments at that point in time. They're not quite sure about when to see people. There is a lot of evidence around the benefits of cancer rehab, and the National Cancer Action Team produced in 2012 a summary of evidence for rehab. So they did a systematic review of all the literature out there. So there's lots of evidence for the benefits of rehabilitation in this group. They also produced in 2013 Cancer Rehab Making Excellent Care Possible, and that's a really good document worth getting hold of because it gives a summary of all the different therapists and what they can do and achieve, and talks about, for providers and commissioners of services, what rehabilitation is all about for cancer. You know all this from everything you've heard today, so the sort of key points from this slide really are that people can have a staging scan and a MET can be identified but they have no neurological deficits whatsoever, or they present with neurological deficits which leads to their either primary diagnosis or the diagnosis of metastatic disease. And again, we need to not assume that metastatic disease means end of life, and I'm sure you've picked up very strongly from today, because there are many more active treatments for people now, survival is improving, therefore rehabilitation is appropriate. In terms of cancer generally, people entering the metastatic stage of their disease may already have existing problems from their primary tumour or its treatment. So there might be problems related to surgery, chemotherapy or radiotherapy. So these are some of the common cancer symptoms that we see with patients. Because of the range of problems people have, it means that AHPs, so when I talk about AHPs, we talk about allied health professionals, that could be physios, occupational therapists, speech therapists, dietitians, and we also work with orthoptics and podiatry services as well occasionally. These people need a wide range of skills and knowledge to be able to manage patients. In terms of brain tumour, these are some of the common problems that we see. So they experience a complex mix of general cancer symptoms along with the neurological symptoms, which do require some advanced clinical reasoning from clinicians working with them. And part of that challenge is taking an excellent case history. You need to get to the bottom of why the problems existed in the first place. Is it part of the treatment that they've had previously? Is it due to late effects? Is it a new symptom as part of the new brain met that's causing the challenge? So some of these problems can be managed. For example, if somebody is presenting with new problems with memory or speech, sometimes they can be addressed by having steroids. Sometimes if they've got new problems with seizures, that can be managed through seizure medication where people's cognition might be affected because of the seizures.
I think it's very difficult with a lot of these problems that cause people to present to rehab professionals. But then you have to backtrack a bit and you have to say, right, well, when did the mobility problem start? Has it crept up gradually or has it come on suddenly? And when you know whether things have crept up gradually or whether they've come on suddenly or whether they've coincided with a certain medication starting, whether they've coincided with a certain treatment starting, then you can sort of think, use your clinical reasoning and think, well, okay, is that reversible? Is it part of the disease? Is it a side effect of medication? And therefore you, as a rehab, talking to the rehab people in here and everybody else, to know and to give your patients some idea as to whether the problem needs to be managed, compensated for, or rehabbed in the traditional sense, as in, are we going to make a muscle stronger? Are we going to make speech, are they going to practice a swallow to make their swallow better? And can it be made better by practice? Or are we going to compensate for it by, other means of thickening fluids or different feeding techniques? So, but it's that kind of clinical reasoning and the background of the case history which can lead you then to know which path you're going to go down for rehab.
Another thing is to think about the goals. You may need to be flexible with the goals that you're setting with people, and they may change because of patients' variability. You need to be able to be flexible, and it may be that you're thinking about achieving goals in a different way. So if somebody wants to be able to get themselves to the toilet, you may think about whether that requires a piece of equipment to do that. So it's about just adapting that as you go along. In terms of the aims of cancer rehabilitation, patients with metastatic brain disease are facing a new range of symptoms, possibly after having had to previously adapt to their original diagnosis. Amelioration of dysfunction is important as this can prevent complications. For example, poor care of hemiplegic arm can result in damage to the shoulder, causing pain and reduced function. Symptom burden, we talk about reducing symptom burden, and that's defined as the subjective, quantifiable prevalence, frequency and severity of symptoms, placing a physiologic burden on the patients and producing multiple negative physical and emotional patient responses. So, for example, pain in the shoulder might reduce sleep, might increase increase dependence and also reduce patients' mood. So when we think about the aims of cancer rehab, these words all look familiar to us, don't they? We talk about improving function, maintaining quality of life, etc. But what I want to think about now, and Sarah's going to talk to you through a case study, is to think about how that impacts upon patients.
Okay, so just a quick case study here, and I have used a breast patient just to give a kind of a bit of practicalities in the rehab sense of what rehab meant to this patient. So a fairly long history, originally diagnosed 2003, and a long period of stable disease, metastatic. Although she had disease in her lymph nodes at the beginning, very long history. And actually, even knowledge of a lung and a brain met, they still carried on with systemic treatment, actually 2 brain mets, carried on with systemic treatment to see if that would help. So she didn't immediately go for SRS surgery or radiotherapy. But eventually, one of the brain mets really didn't show response to the systemic treatment. So she was referred in for surgery, had surgery followed by SRS. So there was a lot of treatment input there. But what I thought if we do, if we just pick out the points where rehab could and did help this person. So initially post-surgery, okay, she wasn't metastatic at that point, so she didn't have brain mets. But the rehab input at that point for a breast patient was education about lymphedema. And I mention it because actually she didn't realise that she had numbness following her surgery. So nerve damage from a wide local excision and mastectomy had caused nerve damage. So she actually had numbness. And later on, this impacted on her recovery, actually impacted on her surgery, because when she went into hospital, they found out she had an ulcer under her arm, which was infected. And then that just delayed her surgery for a few days while they got on top of that. But that's why I mention it, just because she didn't realise she was numb under there at all. She'd no idea. So rehab at that point could have helped. But on diagnosis of metastatic disease, she presented with a seizure. So a first knowledge at all of having metastatic disease was a seizure. She went into a local A&E. And at that point, we'd expect a very quick turnaround through A&E, a scan, sent home fairly quickly. But at that point, she could have had seizure and safety advice. When you're at home and discharged from hospital, quite often occupational therapists are quite good at knowing what is practical within the home for people who are having seizures. So even social services, OTs as well, will look at things like alarms, pendant alarms for people, giving them advice in the kitchen about not carrying, hot liquids, really quite basic things like that. But for somebody who's worried about seizures and dropping hot water all over themselves if their arm starts to shake, it can just give them a little bit of independence back whilst maintaining their safety. This person was very dependent on steroids, as we've heard a lot about steroids, and particularly she had proximal myopathy. She didn't realise she had proximal myopathy from her long-term steroid use for 8 months until she came to be rehabbed post-surgery. And when she started with the kind of general deconditioning post-surgery, trying to get up out of bed, she thought, I'm not as strong as I used to be. And her transfers sit to stand weren't very good. And then we realised it was actually proximal myopathy from the long-term steroid use. So she was given more exercises by the physio than she maybe would have been normally given about quad strengthening, looking at actually increasing, because you can increase the muscle strength and help with that. She also, people don't notice it very much, but she also had weakness at the top of her arms, which again, in itself, probably wouldn't have been a problem, but she had an inattention and a neglect, or what people, I tend to call it neglect if you work in a stroke service, but we tend to say sensory inattention. So she often wasn't aware of where her arm was, and that's a pure symptom of the brain metastases. So she would frequently drop things. She thought it was a weakness, but when you actually dug deep down and sort of found out what her symptoms were, it was an inattention, a sensory inattention, which is a pure neurological occurrence. And we can't go too much into the treatment of things like that, but it's just to try and explain some of the peculiarities that people think it's a muscular problem, or a hemiplegia maybe caused by a neurological problem, and actually it's a bit more subtle than that. It's a perceptual problem of an inattention, and that is quite common. So what she actually had was good rehab post-surgery. She stayed as an inpatient for a little while. She didn't have as much confidence, though, on discharge. She couldn't go straight home, even though you would have said she was probably performance status 1 or 2. She really lacked the confidence in going straight home, and she actually went to stay with her daughter for a period of time until she built up that confidence. And then when she eventually went home to live independently on her own, she had community neuro rehab to work on the inattention, and to work on her general neurological functioning, and they carried on the work with the strengthening of her legs as well. And now she is living independently, going out, doing her own shopping. Unfortunately, she can't drive, but other than that, she's managing very, very well. I have put another case study on here, which will come out with the slides, but I'm mindful of the time, and probably we should get on to asking questions, because we are due to finish at 10 past, aren't we? But that will be on the slides when they come out. I'm just going to mention continuing healthcare, not because it's particularly to do with rehab as such, but it's something that we haven't mentioned throughout the rest of the day, and in the community especially, I think a lot of people diagnosed with metastatic disease would be sometimes eligible for continuing healthcare funding. And just to say that it is something it's worth discussing with rehab colleagues out in the community, nursing and rehab working together to work out whether somebody needs continuing healthcare. But at the moment, I think it's interesting to know the guidelines for continuing healthcare don't really allow somebody to still have rehab. Well, they basically don't want people to be still receiving rehab when you apply for continuing healthcare, because the traditional idea of rehab is that you make the patient better. And what we're trying to discuss with continuing healthcare at the moment is they're not incompatible, because you can have rehab for all the other reasons that Julie said earlier. So the rehab for quality of life, the rehab for achieving your goals in a different way. That's not going to mean that you don't meet the continuing healthcare criteria. We're not going to change those domains that make somebody eligible for continuing healthcare, but rehab is still relevant. But I just thought, because it's something that does come up, but we've not mentioned throughout the rest of the day. Okay.